Hello, everybody. Greetings from Confederation of Medical Association of Asia and Oceania. I'm Dr. K.K. Agarwal. Welcome to our 35th weekly meeting from CMAAO countries. Couple of days back, I had an interaction with the president of the Sweden Medical Association. She is also the president-elect of World Medical Association. She presented the model of Sweden, which I would like all of us to listen. It's a 15 minutes her presentation. That is something which talks about no testing for children less than 6 years, because why waste a test when they have no mortality? Between 6 to 12 years, now they are thinking of testing, made it optional. So from their point of view is, if you really want to go towards herd immunity, you let it happen in the children, because they will increase the level of immunity in the society. They are not insisting on masking, though now they are thinking of masking, but up till now they were promoting no masking. In fact, they even declared that nobody should wear masking in low risk people. And higher risk people, so their objective was prevent the higher risk, and in the lower risk, let it happen slowly, delay it, let it happen towards a herd immunity. That's another model available in a country we would like to listen. Can we have the model?
Can you see my screen?
Yes. As promised, we have getting you a special guest, Dr. Heidi Stensmeier. She is the president of the Swedish Medical Association. She is a consultant anesthesiologist and intensive care specialist in Stockholm. She is also the chairperson of the Swedish Medical Journal. She is the president-elect of the World Medical Association. Now today we have the president-elect of World Medical Association, and I represent the CMAAO countries in Asia as the president. And we will be interacting on the Swedish model. Everybody talks about the Swedish model, where there is no fine if you violate any law of distancing or not wearing a mask, where even actively the government said don't wear the mask. Their job was twofold: protect the high risk and the elderly at any cost, and delay the number of cases occurring in the society, because you cannot make it zero. Let's listen to Dr. Heidi, who will be giving a presentation, and after that we will have a discussion with her. Dr. Heidi.
Thank you, Dr. K.K. Agarwal. I have some slides. Maybe we can bring up the slides. Thank you so much. I'm very happy to be invited to speak. Sweden has a self-picture of having a system for all, full cover, medical cover, good health care. So that's the self-image of Sweden. And this COVID-19 pandemic has made us very humble, because we have failed to protect the elderly, and we have very high numbers of deaths. And what we also see high numbers of other symptoms, especially in physicians, but also the rest of the population, like fatigue, heart rhythm problems, lung problems, and so on. So I will talk a little bit about what we experienced this spring and our lessons learned. Expensive lessons. So it can take, and I myself this spring went into the ICU and worked with the COVID-19 patients during the spring. So I can take the first picture after this one. So here you see, I just brief from start to put the situation right. You see in the red color there is Sweden in Europe. So we are a fairly big country, but we only have 10.23 million inhabitants. So the population is small. And here's the world picture. We're a small population in Europe. And by today, we have 6,972 deaths in COVID-19. That is far, far more than our neighbor countries. And normally we have very tight bonds with our neighbor countries, very tight trades and travel. Now we are isolated. And that's not only because the borders are closed and we have social distances. It's because our relation to the neighbors are not so good at the moment. Because we have a much wider spread. We have the incidence of 613 per 100,000 inhabitants. That's far more. That's like 6 or 7 times more than our neighbor countries have. So I can take the next picture. So here you see again, if you see in the middle, right in the middle, where the red colored in, and all neighbors have lower numbers. So we are normally, and that is a country who's got a self-image of being very good in healthcare. So next picture. So also here, it's interesting to see the numbers first, because sometimes we have done some things good, but the numbers are clear. So here you see the countries of some other countries who have high numbers, like Luxembourg and Montenegro. Czechia is close to us, Belgium as well. But we, Sweden, have 68.47 deaths per 100,000. Makes us fairly high in the ranking, in the not so good ranking list. Next picture. So here is a picture from the subway in Stockholm at the moment. And maybe this picture is 5 or 6 days old. Now the last days they have put more harder restrictions a little bit on us. So, but it will be fairly like this. It's not packed, but too crowded, and there are no face masks. And we can say briefly, lessons learned. We were slow in testing, and we did not scale up testing fast enough. No one had the testing capacity from start. That's okay, but we were too slow. Other countries were in average to lower the R numbers, but when it started the R numbers to increase, everyone started to try to push down the R numbers, the replication rate. We, Sweden, we managed to get the replication numbers down after 58 days. The average in Europe was 30 to 34 days. So we were slow. Okay, so testing, contact tracing is important. Regional restrictions are important, what we see. That's what we have learned. We have regional restrictions, so we are not without restrictions. Prevent spread to elderly people and risk groups. We were early out and said we need to protect the elderly. Yeah, we failed. And the reason was we put everyone at home, all the workers for the elderly homes at home if they had symptoms. But many of them, and we paid for them to stay at home, but many of the people working with the elderly were paid by the hour. They had no employment. They could not afford to stay at home. So we also learned that physicians and healthcare workers are essential. So we had good results when we were pooling over to intensive care. So that helped us treat many. And we also need an increased national governance for healthcare, what we learned. This small country, 10 million inhabitants, have 21 different healthcare systems. And all of them were not coordinated. So next picture. So here is from my intensive care unit, from the spring until now, we have reduced the hospital mortality with approximately 50%. That is both in the ICU and the ordinary ward care. The numbers are a little bit different from hospital to hospital, but in average 50%. And we have looked into many of the reasons and so, but we so far can conclude the anticoagulantia, early start and high dose anticoagulantia and cortisone to push the inflammation down. That's the two main reasons we believe. And of course we have learned to handle the respiration, and we have learned a lot. What we also learned that from start, we thought we would use the basic intensive care treatments and build up basic one outside of the hospitals in military facilities. But we learned fairly fast that to use our high-end facilities and expand them instead with lots of instruments and all the special things. And so rather than building out military facilities outside hospitals. So we used the really high-end ones. Okay, next picture. Okay, so here is Sweden, 21 different healthcare systems and very small capacity, each one of them. So every one of these healthcare systems were out on the international market to try to buy medication, pharmaceuticals, articles, ventilators, all the treatments we needed and all the protection gears. We were too small. We were competing against France with so many millions inhabitants. So we were small, and that we learned. You have to buy things on the international market. You need to be a bigger size, bigger scale, and we were uncoordinated. We also have the lowest number of ICU beds in all of OECD countries. In all of Europe, Sweden is the lowest, 5.8 beds per 100,000 inhabitants. That makes us, so we were starting way behind. We had to double that, and we did double that in 1 week. So we were able to open up and start new. That was good. It showed that we do have the capacity to scale up intensive care. Okay, we also had lack of testing capacity, did not manage to scale up. And in some way, the authorities were not pushing for it. And why not? Okay, if you look at number 4 here in the one, we have regional self-governance, 21 different healthcare systems. All of these they were having their own guidelines and their own decision if to scale up testing or not. And they did not agree on things. So the government did not have the power to tell them to scale up testing. So despite that there was money, there was not being made. So we also had a shortage of doctors in elderly care and municipalities. They did not have doctors. But all the doctors were in the hospitals. And Sweden has a very low rate of family doctors and GPs. So if you look at, in comparison, our neighbor countries like Germany, France, UK, they have high numbers of family doctors who knew the communities and could communicate with the population and the elderly easily by phone because they knew them, but we did not. So we have a lack of GPs in the country. Next picture. Okay, Swedish strategy. Here, look at the GDP. So economy is part of the strategy. So we look at the whole society, not only COVID. So this was the drop in our GDP. It dropped very, very much in Q3. We are exporting dependent country, and without the economy going, there will be no welfare. So we try to have the economy going. We also kept the schools open because we can have click the next button. So, and why was it so, click the next one?
Next, yes.
Okay, yeah, there, thank you. Okay, first one, declaration of a state emergency is not possible in peacetime. So someone said we should start a war against Norway and then we can have a declaration of state emergency. But that was a joke, of course. But Sweden cannot declare state emergency if it's in peacetime. That was important. Even if the government wanted to, they could not. Next one. Restrictions implemented as official recommendations. So when the government were not empowered to make restrictions, they make recommendations. We do follow recommendations, but of course, not as much as strict restrictions. Next one. Restrictions that could be endured for a long period of time. We said early, this is going to take time. If we have too tough restrictions, people will not be able to follow them for maybe 1 or 2 years. That could be debated, definitely. But that was the aim, not to have too high restrictions. Next one. And balance the needs of public health and social economy. Because we saw that we have a drop in the rest of the healthcare system. We need to keep everything up. We need to have cancer treatment, cancer screening programs going, and they were all going down. So we tried to keep everything going despite COVID-19. We also kept the schools open because we say if you close the schools, that's going to be bad for the children who will not get their education. Or maybe women have to stay at home to take care of children, because that's a gender perspective in that. So we kept all the schools open. Next one. And herd immunity was not official part of the strategy, but it can be debated if that was discussed. I know. So we have kept the schools open. Some schools are closed, but more for older people. Universities are closed. Next picture. Okay, I just wanted, this is interesting for the first wave. So if you see the upper picture, that's the incidence, that's the tracking of COVID cases. Okay, so February to August, and the numbers are difficult to read, but we were a slow start. Our tracking and tracing and diagnosis were late on, because the next picture you see, number 2, that's the admittance to intensive care. So they were directly in intensive care before we had a good track of diagnosis and testing. And also the picture, the last one, the number 3, the deaths. They came before we had the testing capacity up. And if you don't test, you don't know what you're working with. Well, you do experience it, but that was a severe lack with that our testing. And we are still waiting for testing. Waiting times to get tested in Stockholm today could be 4 days. 4 days. So that's, of course, a lack. Okay, next picture. And press next. And it spread to elderly care homes. 50% of all the deceased in Sweden are in elderly care homes, not in hospitals. Okay, number of ICU beds was too few. Successful rapid increase. Okay, next one. Cancelled surgeries, major backlog of treatments. We have 100,000 surgeries being cancelled. So that is not good. We are doing the surgery for the cancer treatments, but our cancer screening programs are lacking behind, which means we are not detecting the cancers. So there will be major problems coming up soon. Oh, and we have a reduced inflow to primary care and emergency care. Where are them? Here they are at home and sick. So there will be major problems down the line with this. Next one. And we do have an increase in digital healthcare. And here we'll look a little bit to India, because India is very exciting. You're very good at developing new techniques. But we do have a rapid increase in digital healthcare. And we know the doctors are running them more. They are not nice to have, but they are good ones, good new ones. Okay, next picture. Okay, here again, so is this, I'm not going to show you too many graphs, but it's increasing a lot again, development over time. So we had during summer, that's in the middle, it went down, and then it goes up again in the deaths. And by today, 6,972 deaths. So we are high numbers. Next picture. So, new cases day by day. So here you see during April and June and August, we were quite happy that the numbers were low, but we were expecting a second wave. This is the time of the year where we normally have increased infections in Sweden. We have the flu coming in and other ones. And as you see now, we have COVID. The numbers are up and up and up, but they are still rising. The new cases in hospital from yesterday to today was the same, so we hope that it will be stabilizing. But during November, it has been going up every day and more and more. And we are almost in the numbers of this spring, of the first wave. Not entirely, but maybe 65, pushing 70% of all the numbers we had in hospitals in the spring. The deaths are not that, it's not that high mortality rate in the hospitals because we treat them more rapidly. We have learned to treat them better. But we also see rising numbers of other symptoms and late COVID problems, like, as I mentioned from start, fatigue, heart problems, respiratory problems, and so on. And that is very worrying. So next picture. Yeah, that was the pictures. So that was from Stockholm today.
So I want to come back to one thing, and that is if I want to share the pattern. Can we close it now? So that was Dr. Heidi from the President-elect of World Medical Association. And I want to put it for discussion. The first thing she said was 50% reduction in mortality in the country when they started early steroids and early early anticoagulants. That has been our strategy also and our guidelines also. The second thing she said was the primary schools were never closed. That means they allowed infection to spread in the primary schools. However, the higher schools were closed and the universities were closed. This is a debate because many countries are doing the reverse. They are saying we will allow the higher schools first and the primary schools later, which doesn't make sense. They never went on for lockdown. And she explained that the nation had no authority to put a lockdown. So they had a restricted guidelines, which is, that's another thing. And she said maximum people who died were the one who died in elderly homes. It makes sense that elderly should be protected in their respective homes and not gathered together. Now, further thing she said is that during summer, the cases were less, and in the winter, so this virus is behaving like a winter virus in other parts of the country or other parts of the world also. The peculiar thing she said was that testing takes 4 days in Sweden, which was surprising. It's a high economical country where the testing should be available in 2 hours. But she said in our country, testing may take 4 days with that. And another thing which has come as a writer story yesterday, and they say that Sweden is still saying no to masks. They say Sweden has not needed face masks yet. And they say even after WHO recommendations, they say that WHO says children above 12 years should always wear masks. However, the Swedish Health Agency, largely behind Swedish no lockdown strategy, has refrained from recommending masks, citing poor evidence of their effectiveness and fears that masks might be used as an excuse to not isolate when experiencing symptoms. So the Sweden policy is that if you are symptomatic, isolate yourself And if you are asymptomatic, don't bother. So their assumption is asymptomatic cases do not spread serious infections. That's their assumption. So based on their assumptions, they say whether this assumption is correct or not. So I only wanted to bring the Swedish model to our countries over for discussion. So Dr. Chong to initiate the discussion.
Thank you, President. Welcome everyone again to our weekly CMAAO meetings. Most enlightening to hear Dr. Hedy Sternmyren about the Swedish strategy. She was quite upfront and frank about how, all the so-called mistakes that they had made. And it's pretty surprising for a first world country like Sweden that they are still far behind in terms of testing and the access to testing and the test turnaround time as well. Quite a little bit shocking. And Stockholm, is a home of great institutes like what's that diabetic institute? Very, very famous. Very, very famous hospital. So can't remember suddenly, but it's really quite surprising. And they are still persisting with their stand, and they've obviously alienated their neighbors as well because they've closed the borders. So quite a very enlightening kind of situation that she has outlined for us. I am not sure that other countries would want to follow their kind of strategy unless there was no choice, but it is quite yes. I remember the name of the institute now, Karolinska Institute. That's right, in Stockholm. So this is really a first world nation with a fantastic reputation in medicine. A lot of the big studies came out of Karolinska, especially diabetes and so on. So pretty surprised to hear that this is the state of affairs in Sweden.
So I want to put down one question for discussion.
Yes.
That in a country, so I'm only trying to see not what they learned and not their mistakes. I'm only trying to find out because every experience is every bad experience is also an experience.
Yes.
So for those countries or areas or zones or a house, so I'm going back to a house. Suppose I have a house with very high density with 15 people living in that house, where I say, like Sweden says, lockdown is not possible. So I say lockdown is not possible. Isolation is not possible. I say isolation is not possible. And in that house, I find 4 people are high risk and 11 people are not high risk. So I will move out, taking Swedish into example, I will move out those 4 people in a safer places and let those 11 people wear no mask, develop the disease, develop the resistance. And when all of them are getting affected, recovered, I'll bring those 4 people back. So I'm talking about because what is happening, we are seeing this everywhere in high density places where lockdown is not possible. You can't come out of the house. You have only 1 room or 2 room with 15 people living. In that particular area, instead of you just move out the high risk area, people from that area, move them to a highly, protect them from getting the infection. Let others 11 suffer over the next 3 months, 4 months, 5 months. And when they have recovered, bring them back. For that particular house, herd immunity is over. For that particular house, you have been able to protect. So that's what my mind was working in a literal way, that how can that Sweden model give me an example to any particular situation. So suppose you have a colony of 1,000 people and they can't be, you don't have a space in that particular position. Just remove the elderly people from their contact. Don't keep them like a nursing home together. Those elderly also should not be kept like together, otherwise you will have very high mortality among them. Isolate them totally, and rest of the people can stay. And how about that as a discussion point?
Well, over in Sweden, I guess that's possible. They have quite a lot of land and rural area, and there's a small population in a big piece of land. So that's possible. But on the other hand, the lack of testing and the
That is okay.
slowness in testing will be quite difficult to figure out whether the other 11 people had developed infections and had developed herd immunity. You know what I mean, President? It's a
Yes,
bit
I
tricky,
agree with you, but
I understand your principle. I understand your principle.
I'm only looking for a principle to reduce mortality where to reduce mortality at a time where mortality reduction is not possible. Because if you say that yes, a couple of people have joined. So if you say that in a village where there are 1,000 people, they cannot be removed, then what do? Just protect the elderly. So instead of saying let everybody suffer, we say let the non-risky people, if they develop a disease, it's okay, but at least take away the elderly. That's what they focused on. So they said, let focus on the elderly, protect them, and let everybody develop the immunity.
Dr.
The
Agarwal.
mortality will come down. Yes, Dr. Jamal. The
Yeah.
mortality will come down.
Good morning and good afternoon to Dr. Chong also. He's, I think, more than 12. So anyhow, I just want to just add one thing, whether we can have an answer for that. That they have shown it, it's a second wave. That means the first wave has gone and it was reduced to significant stage. And can we just explain that because their mask was not mandatory and masking, and there was no restriction, but rather recommendations were there. Okay, so how can you explain that?
No,
Why it has reduced?
Because
why it has reduced?
I did not present the discussion part of mine with him because after her talk, I had a long discussion on the same program. So during the discussion, it came out, protect the elderly, separate them, segregate them from the family.
No, but that is only 50%, you know. She has shown it. It is only 50% of the mortality. The other 50% is other people. So the nursing home or elderly home, yes, she has shown it, 50%. So the 50% is a different age group.
Yes.
So that is also significant.
No, 50% was in the nursing homes. She did not.
No. Dead people, number of death cases. Number of death cases.
She said 50% of the deaths were in the elderly living in nursing homes. But there are other elderly who are not living in nursing homes. So one lesson we have learned.
But ensure she has not shown by age, according to age group. She has not shown.
What we are trying to say is number one, that elderly people should not be staying together. One lesson she has given, that high risk people should not be living together. That's one. Okay, that's clear. We all know all over, even in the US, nursing homes, the mortality is very high.
Yeah.
So high risk people should not be living together. That's one message we have got. The second message they are saying is that we want symptomatic cases to be isolated at any cost. So if you are symptomatic, you need to be isolated at any cost. And that's what their basic guidelines are. Symptomatic cases, isolate yourself. Asymptomatic cases, they are not bothered. Because the very fact they are saying less than 6 years, no testing at all. And we know from Indian data, less than 6 years, we are finding children are positive when they are staying together. They may still be spreading infection. So they are indirectly saying is let the infection spread in the country. In low risk population, protect the high risk population. We are not saying whether we agree or not. I'm only discussing the model. And what I said out of this model is, suppose there is a house of 15 people who are otherwise uneducated, all 15 of them, one of them is positive, and they refuse to get isolated, they refuse to get admitted. In that particular situation, I would take away the highest risk people out of that house and let rest of them continue what they want to be. That's what I'm trying to find out, is that their strategy is protect the elderly and let it spread, but slowly in the community. That's what their message, which I got. Their message was, if you are not giving to give them mask, this is symptomatic, isolate the symptomatic, isolate the elderly and protect them. Rest, no need for doing any public health measures. Let them slowly acquire the immunity. That's their
No,
model. I'm not
no,
saying accept
no,
it or
you know,
reject it.
no,
I'm not saying,
WHO,
yes.
WHO warned against the development of the herd immunity, which some countries tried and thought. That is they were against it. I don't think the Swedish model is a unique model, or it's an ideal model, because there are
I
number of cases, and if you see that that was near about 6,000 in 1 million. 6,000 in 1 million, the incidence rate. And the death rate also is quite high in comparison to their population. So actually, I don't know, but just my question was that how it reduced actually the infections. That is my question. If the mask is not necessary for those people, so why we are just keep it seriousness on masking, on giving masks?
I
That's the thing.
I said one thing very clearly, that we are not, they themselves are saying our model is not good. They themselves are saying our model, we have done lots of mistakes. But I'm only trying to find out is that out of these mistakes, can we learn some positive points? So the first positive point we have learned is that if your testing is available after 4 days, your number of cases will go on increasing. Second thing we have got is that if you segregate people, all high risk people in one area, and if they develop infection, the mortality will be very high. Therefore, high risk people should not be living together in any nursing home. That's a message we have got. The third message we have got is that that is a debatable now, and that is let the infection spread in people who are less than 6 years of age. This is something will be debatable always and will be a matter. I personally agree with them, because children less than 6 years, all those children to whom I have seen so far, I said they will recover themselves within 2 days, and that's what is happening. We are not seeing multi-system inflammatory disease in age 2, 3, 4, 5, very rarely, though we do see such cases, but most of them are recovering. So therefore, that's the reason that till now, no vaccine trial has taken children between 0 to 6 years. All the children's trial are in age group of more than 12 years. So therefore, that population, which is around 11 to 12% population in India, will get infected and will add to the herd immunity, all the children. The next thing they are saying is that masking versus isolation. So they says, if you are symptomatic, isolate yourself. In isolation, you are alone, so no masking is required. But if you are not highly symptomatic, then indirectly they are saying, if you say no masking, then you are saying let the infection slowly spread in those people where mortality is very low. The mortality cannot become zero, mortality will be there. What they are saying is over a period of time when you are going to get infection. So we are not discussing whether we should adopt a Swedish model or not. I am only looking at one point of Swedish model. Say we are facing this problem every day in India. There are houses where 15 people are staying together in one room or two rooms. I recall my own family, my childhood, we were 12 people in one single room. We used to live in one room, 12 people. So I can imagine people living 12 to 15 people in a 1-bedroom set or a 2-bedroom set, where and we are getting, even now, as most of my families which I'm seeing, this is 23 people affected. Somebody says 16 people affected. Right away, I have a family, 23 people in one family in the same house getting infected. Now, in those particular situations, if suppose I have one person infected out of those 23 and they are not willing to get admitted, they are not willing to go out, then I should immediately shift high risk individuals from there and protect them. Rest of the people who are not high risk, if they live together, even if they get it, that's what Swedish model gives me a hint that how to manage those cases. At those moments, they say, doc, we are not going to listen to you. We are 24 people, let everybody suffer. We are not going to go out. We can't afford hospital. We can't afford anything. So let it happen. So there I'm saying is, if we shift highest risk people and protect them somehow, and in that particular house, we are not talking about a country statistics. So then if you can protect the highest risk, you may be able to put something to reduce the mortality. So this is applicable in Pakistan, India, Bangladesh, because we have houses where 20 people live in one house. There, how do you protect the elderly? That's my question.
President, can I ask a question? How did Dr. Heidi Steinmeier, how did they protect the elderly? They moved them out of the houses?
They says we have enough places.
Okay.
So there is no shortage, there is no density population issue. So they said we shifted them out. They opted to go out and in enough spaces. So my mom is 95 years. Okay, my mom is 95 years. She is still alive. And I asked her, do you recall Spanish flu? Okay. She was born 7 years after the Spanish flu. Okay, so she was born in 1920 something. So when I asked her, she says, yes, I have heard about it.
Okay.
So I said, what did you hear about that? She says, I used to ask my mother that why people from my grandfather don't come and visit us. She said, I've never seen my grandfather's family. So she used to ask her mother that why don't people from our grandfather visit us? So she says, I'm talking about, she's telling me now at this time.
Yeah.
So she said, my mother used to tell me there was a mysterious illness which came in the villages. There was a mysterious illness which came in the villages, which was fever and cough and breathlessness. 20 million people died in India at that time. Okay.
Wow.
And she said everybody was dying. So the whole family of ours died.
Wow.
Okay. So then she said, how did you survive? The mother. Mother's mother died. She asked her, why did you survive? So she said, couple of us, we ran away from the houses and started living in the, what do we call them as? खेत को क्या बोलते हैं? Sanchita?
Field. Field.
In the field.
In the field.
Wow.
So they said we started living in the field where we used to grow vegetables. So we created a temporary shed and we lived there for a year and we survived. That's what I'm saying. Elderly people should come out and start living in an open space. So in the field, it was an open field where they were looking after their farming and they lived there. All those people who started living in the field, they survived.
I see.
I mean, that's what she says is to me now at the age of 95. That's her experience with that. So I'm only trying to say is that if you shift elderly people in the family, if there is a case, I'm not talking about without a case, instead of letting them get infected, okay, number one. Number two is, suppose there are 15 people in the family and the parents, two parents aged, say 80 years of age, rest of the 13 people in the family, if they get infection one by one over the next 1 year, the parents have to be out for 1 year. And if all non-race people get the infection, in 15 days, the whole family has recovered. I'm not recommending anything. I'm only trying to get a lesson out of Sweden, because they said that let the infection spread in asymptomatic people, isolate symptomatic, and isolate the elderly. Whether it is correct or not,
Here in this
nobody to
region,
say. I'm nobody to say, but that's
Yeah.
what the Swedish model is.
Yeah. But here in our region, it will be difficult. But it is possible if you have a separate room in your own house, in his own house. Then it is possible also here to segregate them, not to mix with other people, other members of the family. So that is possible in that house. Otherwise, our customs doesn't allow actually these people to take away from the house.
No.
And,
Away means they can be in one floor if there are 2 floors, and rest of the people can mix together and have the infection. So what I'm trying to say is it's ethically, Dr. Russell will say big no. It's unethical to have people living together if one of them is positive and not wearing a mask. I agree. But if a family comes and says that we are not going to wear a mask, and then what should we do? Then my answer as a medical practitioner will be that you save the high risk. Do not get them exposed. That's what I'm trying to say.
But in Malaysia, wearing a mask is mandatory. It's law. So you cannot be seen without a mask out of your house.
Yeah.
They will immediately arrest you or fine you and say you have broken the law. So it's mandatory in Malaysia to wear a face mask.
So I'll tell you the Indian law for that. I will tell you the Indian law for that. The Indian law is very clear, and which is much more stricter than any other country. And the Indian law is that section 270 in the Indian Penal Code, it's a criminal offense. Malignant act likely to spread infection of disease dangerous to life, which is COVID-19. Whoever malignantly means knowingly does any act which is and which he knows or has reason to believe to be likely to spread the infection of any disease dangerous to life shall be punished with imprisonment of either description for a term which may extend to 2 years, or fine, or with both. So the law is there. This law is there for the last 50 years. The law
but not
is
implementation.
I mean, you are talking about fine.
Not implementation.
No. This law is very clear, applicable to COVID-19. If you don't,
but is it implemented?
Yes, it is.
Partly implemented.
No, you're not understanding. To dilute this law, people have come back and says 2,000 rupees fine. Otherwise, every country, when they bring a fine, means you are diluting an existing law, and the existing law is 2-year imprisonment. So they have said or fine. So they have come out with an office order by saying this much fine. Mandatory it is there in every country who is a British controlled act. Any country which was under the control of British sometimes back, this law will be there, because this is basically a British law. This is India can't create her own law, because when India started independence, they only modified the British law. So this law is already there in every country. Even if you need Bangladesh, if you see, you will find a Bangladesh penal code where this law will be there. But to dilute this law, government will come back and say, okay, we will have only 2,000 rupees fine or 1,000 rupees fine.
Correct.
Even in Malaysia, this law may be there.
Yeah, but they have now made it a law to wear the face mask, and if you do not wear, they charge you a 1,000 ringgit fine if you're caught without a face mask.
This is a dilution of existing law. So you have converted a violation from a criminal offense to a civil offense.
Civil offense, yeah.
But if you see your criminal, the law will still be there in the criminal part.
Mr. President, but however, until last month, the WHO still said that wearing a mask is not helping to stop the infection. And so this law would not apply to not wearing a mask if WHO said wearing a mask is not necessary. So of course now WHO had changed the stance that wearing a mask is necessary above 12 years of age. So even WHO had not really opined that wearing a mask is necessary before last month. And so it's the many of the countries of the Western world. So I think that is something that puzzled us.
No, Dr. Alvin, they have changed. Actually, initially it was there, taking the conditions in the developing countries, the least developed countries, they said it. I understand it. But later they have shifted from that here, and they have given a separate guideline. They said, no, mask is there.
I agree with you. I agree with both of you. But I want to give it back to Dr. Chong to sum up by saying one word, that mandatory masking outside the home. We are not debating that. That because we are debating masking inside the home when one person is positive. If there are 10 people at home, one person is positive, rest 9 are exposed but not positive. Isolation is not possible. Of those 9 people, what to do? Should they wear mask at home or not? If you wear mask at home versus no wearing of a mask, in that situation, if you can't wear mask at home, at least protect the elderly and shift them in isolation. That was my lesson from this Swedish lecture. Though I don't agree with their policies, but at least I got one message that within a family, if there are 10 people who are exposed, protect the elderly first. Give first preference when you're talking about vaccines, priority. So priority of within the exposure, the priority should be the elderly. If only out of 10, only 2 masks are available, give it to the elderly and not to the other people. That's what I wanted to say. I'll request Dr. Chong to sum up.
Thank you, President. And again, most interesting discussion today based on the Swedish model. In fact, what I see is that the family or the family home is a microcosm of the nation.
Yes.
And in this particular situation is because in certain countries, whether by resource or otherwise, for example, Sweden has a lot of resources, but obviously they don't have a law that allows a lockdown and so on. But for example, maybe in a lot of other countries where there are not enough resources, then a lot falls onto the microcosm of the family itself to deal with the crisis. And I think the lesson you have pointed out is that in the microcosm of a family, certainly removing the elderly and protecting them is vital. And then allowing the rest to develop herd immunity in their own time and space. I think that's the message we are trying to say. Of course, in Sweden, it's because they have some issues with the law and so on. And I think the Swedes also pride themselves on being able to have a lot of self-responsibility, and they prided themselves on being able to deliver that discipline and that outcome that they wanted. But unfortunately, it did not happen. I think they really relied a lot on individual responsibility and knowledge, which kind of fell short. So perhaps that is also another lesson that we've learned from the Swedish, that personal responsibility is great, and if you think you can do it, that's fine, but sometimes it still falls short. So with that in mind, I think that's probably the lesson we learned today, these couple of lessons. And without much further ado, I thank everyone again for coming to this wonderful session that we have every Saturday. And thank you all again, and thank you, President, for today's session.
Thank you. We'll be back
Thank
next time. Next week.
Thank you. Thank you, KK.
Thank you, everybody.
And
Thank you, everybody.
Dr. Chong, thank you very much.
Thank you.
Thank you always. Thanks a lot.
Thank you. Mari,
Thank you.
Thank you.